Hi everyone, today we'll be discussing about short cases in ophthalmology. So it's a part of practical discussion. So the commonly given short cases are pterygium, chalazion, hardylium. Rarely the patient comes, and very rarely corneal ulcer and DCT. So today we'll be dealing with mainly pterygium and chalazion and hardyliums. Okay, pseudophakia will be dealt by ma'am, Satyaj ma'am, along with the cataract. So coming to short cases. So short cases differ from long cases. No need of taking a detailed history and a detailed examination or presenting in a detailed manner in case of short cases. So only preliminaries and chief complaints are required. On examination of only the affected eye. No need of mentioning the findings of the other eye. Though you need to examine both eyes, but you need to mention only about the findings of the affected eye, and only positive findings have to be mentioned. It's not like you're not supposed to examine. You're supposed to examine both eyes, but you need to present only the eye which is affected as well as only the positive findings. And only the chief complaints has to be taken. No need of elaborating the chief complaints. The history of presenting illness can be told, but in a very simpler form. No need of going for a complete detailed history. And coming to the first case we will be discussing is pterygium. So as you know, any case presentation will start with preliminaries like name, age, sex, occupation, complaints, followed by examination, and followed by provisional diagnosis, and then differential diagnosis. So in case of pterygium, so in case of in any case, like why this age is important, why sex is important, why occupation is important, I think so all of you know. But in case of pterygium, so similarly like age, so if the patient middle-aged people, and as the age increases, the incidence of pterygium increases. Now it's more common in males when compared to females, and it's more common in outdoor working population, like who are working in more sunlight, who are more exposed to radiations or sunlight and dust. They are more prone for pterygiums. So that's the reason we need to take this preliminaries. And so coming to discussion regarding pterygium. So what is pterygium? So as you all know, pterygium is a triangular or wing-shaped encroachment of the bulbar conjunctiva, or from the bulbar conjunctiva onto the cornea. Okay, so in this picture as is shown, you can see both nasal as well as temporal pterygium. Okay, so this is also called double pterygium. This is also most commonly asked question. So what is double pterygium? If the pterygium is present both on the nasal and temporal side, it is called double pterygium. So according to the definition of pterygium goes like this: it's a wing shaped or triangular shaped encroachment from the bulbar conjunctiva onto the cornea. Each and every word is important. Okay, so it is encroaching on the cornea. If it's not encroaching on the cornea, it doesn't come under pterygium. There are other degenerative conditions. Okay, so and it's a degenerative condition. So the complete definition you can tell, it's a degenerative condition of the cornea wherein a triangular shaped encroachment from the bulbar conjunctiva onto the cornea is seen. So coming to the risk factors of pterygium. So as I told already in history taking, so environmental irritants and exposure to sunlight is the most important risk factor for pterygium. So what are other risk factors? Like genetic predisposition can be present, and advancing age groups, like as the age increases, they are more prone for developing pterygium. And I told you men are twice infected than females. It's mainly related to their outdoor working environment. And another important thing is the site of the pterygium. Though it can be seen both on the nasal and temporal side, most of the pterygium, majority of the pterygium you see will be on the nasal side. It has the same reason, more exposure of there is more exposure of nasal conjunctiva to the sunlight when compared to the temporal conjunctiva. I will be telling you the reasons for that. So coming to the environmental factors. So as I already told you, there is a strong epidemiological correlation between the pterygium development and exposure to sunlight, like long exposure, or people working in outdoor environment, or people, like example of a farmer by occupation, or people who has to continuously get exposure to the sun rays, they are more prone for development of pterygium. And genetic predisposition, there is a concept of two-hit hypothesis in case of pterygium. Like as you already know, Knudsen two-hit mechanism, wherein the first hit is a process wherein a tumor suppressor gene is deactivated, which is inherited, whereas the second hit is influenced by environmental factors. It could be a viral infection or a UV radiation. So as I told you, ultraviolet radiation exposure is the most important risk factor. It is postulated that ultraviolet radiation hits the limbal stem cells and hence cause alteration in the limbal stem cells, which is associated with activation of multiple pathways, like activation of free radicals, which in turn attack and deactivate various macromolecules. Other risk factors was already discussed. And coming to the site, I told you more common site is nasal site, nasal interpalpebral area, or nasal pterygium. So light, the reasons for that are as follows. Like because more light is reflected onto the nasal conjunctiva. So the reflection of light onto the nasal conjunctiva is because of the nasal bridge, the nasal bones, which reflect the light onto the nasal conjunctiva, more onto the nasal conjunctiva when compared to the temporal conjunctiva. That is one of the important reasons. The other reasons are because of the long eyelashes which are present on the temporal part of the lids. They somehow have some protective mechanism. They prevent from temporal conjunctiva from more exposure of sunlight. That is one reason. And the third reason is because of the lacrimal pool. Like as you know, the tears are secreted from the lacrimal gland, and they flow from temporal side to the nasal side and are drained through the punctum to the nasolacrimal duct. So there will be a lacrimal pool or on the nasal conjunctiva, so which carry all the dust particles, and thus causing further irritation more to the nasal conjunctiva when compared to the temporal conjunctiva. So another most important asked question is which part or which pterygium is more common, either nasal or temporal. So the answer is definitely nasal conjunctiva, and the reasons are as follows. So coming to the pathophysiology, like I told you, ultraviolet radiation exposure is one of the most important risk factor. And because of the exposure to ultraviolet radiation, there are a series of changes which happen. So the most important postulated hypothesis is the ultraviolet rays genetically alter the limbal stem cells which are present across limbus at the corneoscleral junction. And due to chronic ultraviolet radiation exposure, there is a breakdown of the corneoscleral limbal barrier. So ideally the conjunctiva doesn't grow on the cornea because of the limbal stem cells. They provide a barrier and they prevent the conjunctivalization of the cornea. So because of the damage of the limbal stem cells, or because of the genetically alteration in the limbal stem cells, there is a breakdown in the corneoscleral barrier, which results in subsequent conjunctivalization over the cornea. Okay, and you know the limbal stem cells, any stem cells are responsible for healing, they are responsible for proper ocular, like normal ocular surface. So if there is an epithelial defect, ideally these limbal stem cells, they proliferate and they cover the epithelial defect. So limbal stem cell deficiency is again a separate topic, but one thing you have to remember is pterygium main pathophysiology is mainly because of ultraviolet radiation causing damage or causing alteration or genetic alteration in the limbal stem cells. Hence, the barrier effect of limbal stem cells is lost and it causes conjunctivalization or conjunctivalization of the cornea, resulting in pterygium. So, these are the other pathophysiological changes which occur. So, this is not of much importance to you. Then, coming to parts of pterygium, like you can see in the picture. So, as the definition goes, it's a triangular shaped or a wing shaped encroachment of the bulbar conjunctiva onto the cornea. So, you can see a triangular shape. So, this is a triangular shaped fold. So, it has cap, head, and body. So, this is the cap, like it's shown in the picture. It has cap, head, neck, and body. Cap is nothing but the apex. So pterygium is classified into progressive and atrophic pterygiums, or atrophic, or alternatively you can call regressive pterygium. Some people don't agree with regressive, so you can just classify into progressive and atrophic pterygiums. So what are the differences between progressive and atrophic pterygium? So progressive pterygium is thick, fleshy, like you can see in this picture. It is very thick, fleshy, and it has a prominent vascularity, and it is gradually increasing in size and encroaching towards the center of the cornea. In history itself, so the progression, I mean, it's progressing or not, that is important. So you need to ask whether the pterygium was stationary or whether it is increasing with time, whether it is associated with any redness on and off. So these are all signs of progressive pterygium. And in case of progressive pterygium, like you can see in the picture, there is a opaque spot or infiltrative spot just in front of the apex of the pterygium. Okay, so that is cap. And ahead to the cap, there is a deposition of iron. So ahead to the cap, there is a deposition of iron. So like you can see in the picture, like it's in the shape of a line. So that is called Stoker's line. So in the picture you can make out this pterygium. It is thick, fleshy, more vascular, and definitely you can see a cap, like opaque spot ahead to the pterygium, as well as Stoker's line, which is iron deposition. So all the pterygium, all the progressive pterygium need not have this cap or Stoker's line, but definitely they'll be thick, vascular, and fleshy when compared to the atrophic pterygium. So the next is atrophic pterygium. So atrophic pterygium, how do you differentiate from progressive pterygium? One is by the history. So it's usually stationary, it doesn't progress. Then coming to the examination, it is thin. The pterygium will be very thin and without much vascularity, very poor vascularity, and it will be attenuated. And you won't see any cap or Stoker's line. It's stationary, like I told you, and ultimately it becomes a thin membrane. But one thing you need to remember is that the pterygium never disappears. So this is the differentiating features between progressive and another pterygium you need to remember, like I told you in the first slide, that is double pterygium, which I have put, which is present both on the nasal and temporal sides. That is double pterygium. This is also most commonly asked, what is double pterygium? So if you see both nasal and temporal pterygiums in the same eye, it is called double pterygium. Now I'm coming to the clinical features. So many small pterygiums are asymptomatic. They won't have any symptoms, so mainly they might have noticed accidentally by seeing in the mirror. So but a few pterygiums, especially progressive pterygiums, they can be associated with symptoms. though not continuously. They can have intermittent symptoms, like they can have some congestion, irritation, dryness, tearing, foreign body sensation, and some people will have decreased vision. It's mainly because of two reasons. One is, if it's a progressive pterygium, if it encroaches over the cornea, even the pupillary area, it causes decreased vision. Another most important common thing is because of the astigmatism caused by the pterygium. Since it encroaches over the cornea, it causes flattening on that part where it is encroaching, leading to astigmatism. So this is the most common cause of vision, decreased vision in case of pterygium. So they'll ask you what are the causes for decreased vision in case of pterygium. So most important thing is astigmatism, because so the progressive pterygium encroaching the pupillary area occurs in a very lesser percentage when compared to astigmatism. Astigmatism, even if it encroaches in 2 millimeter or 3 millimeter into the cornea, it can cause astigmatism. Whereas for the pterygium to encroach into the pupillary area, it will take a longer duration. And other important cause for vision, disturbance of vision, you can tell is theophyllum instability caused because of pterygium. So coming to grades of pterygium. So this is also a common question. So how do you clinically classify pterygium? So one is based on the extension, how much it extends into the cornea. So type 1 is, if it extends only up to 2 millimeter of the cornea, it is called type 1 or grade 1. So grade 2 is, if it extends 2 to 4 millimeter into the cornea, it is called grade 2. And grade 3 is if it encroaches more than 4 millimeter into the cornea, such as almost touching the pupillary area or almost covering the pupillary, it is grade 3 pterygium. Okay, there is something called TANS classification. You just need to remember the name, and details is not required. So this is based on underlying episcleral vessels visibility. Like if it's episcleral vessels are clearly visible, it is grade 1. If clearly underlying episcleral vessels are seen, it is grade 1. If it's not seen so clearly but still seen, it's grade 2. If the episcleral vessels are totally obscure, it is called grade 3. Just remember there is something called transclassification, but most important is based on the encroachment. So coming to the differential diagnosis, so the most common differential diagnosis are, one is pseudopterygium, then pinguicula, then nodular episcleritis, and flicton, then conjunctival carcinomas in situ, like not a full-blown conjunctiva, it's carcinoma in situ, and limbal tumors like benign limbal tumor like limbal dermoid, or ocular surface squamous neoplasia. You just need to remember all this differential diagnosis, but the most important thing from which pterygium has to be differentiated is pseudopterygium. So what are the differentiating features? So we need to mainly differentiate pterygium from pseudopterygium. Pseudopterygium is nothing but a fold of bulbar conjunctiva similar to the pterygium, which is attached to the cornea. So the main pathology in this is, it is due to the adhesions of bulbar conjunctiva to the corneal ulcer. So that corneal ulcer could have occurred mainly because of anything like a trauma or previous surgery or chemical burns. Because of some inflammatory process, the bulbar conjunctiva would have been inflamed and it would have been chemosed and it would have attached to the cornea. So it can occur at any age group, unlike the pterygium, which usually occurs in the middle age or increases with age. And pseudopterygium, the site, it's not usually 3 o'clock or 9 o'clock position. It can appear anywhere on the cornea, and it's always stationary, unlike the pterygium, which can be progressive, regressive, or stationary. And another important differentiating feature is it's adherent to the limbus. So it doesn't adhere to the limbus, so it's not firmly attached to the limbus. So when you pass a rod, the test, what we call it as rod test, when you pass a rod at the limbus, you'll be able to pass a rod below the pterygium, whereas in case of pterygium, you won't be able to pass a rod because it is firmly attached to the limbus. So what are the differentiating features? pseudoterrorism, it's mainly secondary to inflammation. Any inflammation, could be trauma, surgery, or burns, peripheral burns. Then it's always stationary. It can occur at any site, not only at 3 o'clock or 9 o'clock like the pterygium. It's either nasal or temporal. It doesn't occur any other site, whereas pseudoterrorism can occur at any site, and it is always stationary. It doesn't progress. And another important differentiating diagnosis is it is not it doesn't adhere to the limbus, unlike the pterygium. So you can pass a rod below the. So coming to the other differential diagnosis, uh, pinguicula. So pinguicula is also one of the important differential diagnosis, but the most important feature in case of pterygium is it encroaches onto the cornea, whereas pinguicula, it's also a degenerative condition which is limited to the limbus. And coming to nodular episcleritis, so it also doesn't encroach the cornea, so it appears as a nodule, painful nodule at the limbus. So coming to flicton is nothing but a necrotic lesion uh, surrounded like a marked telangiectatic surrounding vascular lesion and ulcerated surface which stains with fluorescent. It is thought to be because of hypersensitivity reaction to tuberculosis or staphylococcus. Then marginal keratitis is one of the differential diagnosis. Then in like Bowman's disease, carcinomas in situ, not like a full-fledged carcinoma. It's carcinomas in situ, and limbal dermoid is another important differential diagnosis, and ocular surface squamous neoplasia. So here you can see a pseudoterrorism. See, this is not a typical side. It's not on the nasal or temporal side. It's on the inferior side. Okay. So another things you won't be able to appreciate much, this rod test and all. Okay. And coming to management of pterygium, like anything, medical management. So when do you need to operate, that we'll discuss later. So coming to the medical management, mainly it consists of tear substitutes, because it causes even tear film instability I told. So tear substitutes, and if there is inflammation, like if the pterygium is inflamed, then we need to temporarily give some relief drops for the relief, like steroids, and advise sunglasses to avoid exposure to ultraviolet rays. And coming to indications, so we need not operate all the pterygiums. See if the pterygium is atrophic, if it's stationary, if it's not progressing, and if the patient is not motivated. So we need not operate. Go ahead and operate pterygium. So what are the indications for surgery? So one is definitely if it's a progressive pterygium and if it's extending to the pupillary area, definitely we need to operate. Then if it's causing decreased vision because of significant astigmatism, then also we can go ahead and operate. And if it's causing recurrent irritation or recurrent inflamed pterygium, like if the patient complains of frequent on and off redness, then also we can go ahead and operate. And rarely cosmetic indication, if the patient, though it is stationary, it's small, if the patient wants to get rid of pterygium, we can go ahead with a surgery. So these are the main indications of pterygium. So now coming to the operative technique. So the initial operating technique is same, like excision of pterygium can be done in different ways, followed by placement of graft or no graft, that we'll be discussing later. So the basic operative technique I'll be telling you. So the operative technique, what we are commonly doing is pterygium excision with conjunctival limbal autograft. So every word in this is important, like excision of the pterygium, conjunctival excision or pterygium excision with conjunctival limbal autograft. We are taking the conjunctival limbal autograft. We are not taking any free conjunctival graft. We are taking along with the limbal cells. So it is called conjunctival limbal autograft. This is the most common operative technique which is done. So right now I'll be showing you the pictures of pterygium excision. So here eye is anesthetized, it can be done both by perivulvar and topical anesthesia. Tracts and sutures are present, just like any surgery, to stabilize the globe, followed by marking of the pterygium. Like so, you can see a marker, right? So that is a pterygium portion which is marked, and you can see in the picture a blade is used to dissect the head and neck. There are different techniques in this dissection and removal of the pterygium. This is one of the technique. So using a blade we are dissecting the head and neck of pterygium back to the limbus. Then head of the pterygium is avulsed, like it is held and it is avulsed from the cornea, and any underlying residual fascia, subconjunctival. See, one thing I forgot to tell was, so what is, pterygium is a degenerative condition. It occurs with the advancing age, and it's a degenerative condition of the cornea. So what type of degeneration, that is also important. It is a allostatic degenerative condition of the cornea, of the of the subconjunctival tissue. So all the words are important. It is an allostatic degeneration of subconjunctival tissue which is triangular in shape and encroaches the cornea. So this completes the definition. So I have not mentioned anywhere about this allostatic degeneration. You just note it down. So it's a allostatic degeneration of subconjunctival tissue, not the conjunctiva. It's a subconjunctival tissue which appears in the wing shaped or triangular shaped and encroaches the cornea. So here, so the pterygium avulsion, excision includes the removal of subconjunctival tissue. So any residual attachment of the fascia and conjunctiva has to be removed by using a 15 number blade on the cornea, and we have to minimize the removal to prevent post-op astigmatism, and along with sharp dissection of conjunctival portion of pterygium, like below the conjunctiva, whatever the pterygium is there, we have to excise it. After avulsing the conjunctiva which is present on the cornea, we have to remove the subconjunctival tissue. We have to remove the pterygium from the underlying conjunctiva on the conjunctival side also. So this is the basic excision of the pterygium. So even like a cataract surgery, even pterygium surgery have evolved. Like initially they used to just excise the pterygium and used to just leave it like that without any flap or without any graft or any graft. So previously what they used to more commonly do was a base clearer technique, but which led to a lot of recurrences. So in almost base clearer technique, the recurrence rate was as high as 5 to 68% in case of primary pterygium and 35 to 82% in case of recurrent pterygium. So recurrence rate was very high. One of the most common complication of pterygium surgery is recurrence. So our main goal is to prevent pterygium recurrence. So initially when more of base clearer technique was done, the most common problem which they used to encounter was recurrence. So hence they thought of other procedures like closing the conjunctiva just by sliding the flap, of the conjunctiva adjacent to it, or by rotating the conjunctiva adjacent to the excised pterygium. It is called rotational flap. Or taking a free conjunctival autograft, like I told you, that is most common technique. Taking the conjunctival graft from the other side, like if it's a nasal pterygium, you can take the graft from either temporal or inferior part. So that graft has to be a limbal autograft. So that is a most common technique we use, and that graft has to be placed in the area where you have excised the pterygium. So what are the methods used to stick the graft? So previously they used to put more of sutures, like they used to put sutures, or they used to use, later on they started using fibrin glue. The disadvantage of fibrin glue was it was costly, and it is costly when compared to the sutures. And sutures Though it is a cheaper technique, it used to lead to a lot of suture related problem like suture irritation or suture granuloma. Imagine having sutures in eye, so you'll have a lot of irritation, granuloma, and problem post-op recovery is delayed. So this was the most common problem encountered with the sutures. Whereas glue, it was costly, though it had very less post-operative side effects. It is costly, and nowadays most of them have shifted to autologous serum. It is nothing but the when you excise the conjunctiva, there is a blood clot, there is a bleeding which occurs. You just allow the blood to stay there, which acts as a serum, autologous serum, like and just put the graft in that. Because of that adhesion properties in that, it will get attached to it. Okay, so the most common technique nowadays what we are using is uh, conjunctival limbal autograft without any sutures and glue. So the other graft other than conjunctiva what we can use is amniotic membrane graft. So when do we do amniotic membrane graft? So the best one is to use a conjunctival autograft, but in certain cases where already you have done a conjunctival autograft and there is recurrence, then there is no conjunctiva left to take the graft. And in case of double-headed pterygium, like I told you previously, double pterygium or double-headed pterygium, where both it is present on nasal and nipple, where you don't have sufficient conjunctiva to take the graft, you can go ahead with amniotic membrane. And so this method minimizes the risk of injury to the rest of the conjunctival surface. However, it is costly, like you need to purchase a graft. So what is amniotic membrane? I think everyone know it's nothing but a part of the placenta which has to be processed. So there has to be entire processing which has to go on. So it is so we are able to use it. So the properties of amniotic membrane, you just read it. So why it is used in case of a pterygium, like why it is used as a graft, what are the properties of amniotic membrane which prevent, why we are using graft mainly to prevent the recurrence. So what are the properties of amniotic membrane which helps in preventing the recurrence? Like I told you, conjunctival limbal autograft is used to prevent the recurrence. So mainly because it contains limbal stem cells, and limbal stem cells, they help in preventing the growth of the conjunctiva over the cornea, and they have many properties which prevent the recurrence. So similarly, even amniotic membrane also has few characteristic features to prevent the recurrence. So you just read about it. And another rarely performed thing for pterygium is lamellar corneal transplant. Like it may be required rarely in case of recurrent pterygium. If there is firm adhesions to the corneal stoma, it is very deep. So one thing you need to know about pterygium is it is firmly adherent to the cornea. It penetrates the almost Bowman's membrane, and sometimes beneath it. It penetrates even the anterior stroma. So when you are avulsing the cornea, there can be a large corneal defect, and sometimes very rarely you need to do a lamellar corneal transplant. So you need to remember it is done very rarely. It is done in cases of a recurrent pterygium with firm adhesions to the corneal stroma. So it acts as a barrier against pterygium recurrence and to replace the thinned and scarred cornea, because if it's thin and scarred, it can lead to significant astigmatism and sometimes can lead to perforation. So very rarely we also do lamellar corneal transplant. Just place a lamellar transplant. So it can be done along with amniotic membrane transplant. So even along with the lamellar corneal transplant, you can place even amniotic membrane to prevent recurrent pterygium. So what are the adjuvant therapies for pterygium? Like like nowadays mostly we are putting the graft. It could be either conjunctival limbal autograft or amniotic membrane graft if required, or so what are the adjuvant therapies which we have been using? So why this adjuvant therapy is required? Again, to prevent the to reduce the recurrent rate. So a main aim in case of pterygium surgery is to reduce the recurrence rate. So previously they used to use beta radiation or thiotepa, which are obsolete now, which we don't do. And the most common adjuvant therapies which we have been using are mitomycin. So the percentage, few people are more fond with the percentage, they skew about percentage. So it is 0.02%, which is applied for 3 minutes during the surgery. So this you need to remember. So we applied 0.2% mitomycin on the excised area or the bare area, and thoroughly wash it with large amounts of saline, so that any precipitant or any mitomycin is not left, and then place the graft. And recently even anti-VEGFs, like anti-VEGFs is again a separate topic. You just remember even anti-vascular endothelial growth factors like bevacizumab, Lucentis have also been used to prevent the recurrences. So all this adjuvant therapy so mainly aims in reducing the recurrence. The most common adjuvant therapy which we have been using is mitomycin, and of late recently even anti-VEGFs have been tried. So coming to the complications. So of pterygium treatment, like as such pterygium doesn't lead to much complications. Operative complications related to pterygium excision are very uncommon, but unlike any procedure, and like any medical profession, any procedure has its own risk. So rarely it can lead to, there can be occasional excessive bleeding when you are excising the pterygium, or when you are taking the flap, there can, because it's a very thin flap you need to take, so there can be buttonholing or a tear in the conjunctival graft. Rarely when you're putting sutures, very rarely it can lead to perforation. Or another important thing is injury to the medial rectus muscle. So because this pterygium, most common site of pterygium is nasal side when you're excising the pterygium, so you have to be careful not to dissect more on the nasal side, because the incision of medial rectus is, when compared to other recti muscle, the medial rectus is more close to the limbus. So during the excision of subconjunctival removal of the pterygium tissue, or the excision of pterygium on the conjunctival side, you need to be careful while dissecting, so that you don't cause injury to the medial rectus muscle. So these are the intraoperative complications. Coming to the post-operative complications. So post-operative one of the, I told, like most common post-operative complication is recurrence. So we have been modifying the techniques to avoid the recurrence. So currently the recurrence rate has reduced. What are other the post-operative complications are also less in case of pterygium. So other post-operative complications include Dellen formation, or persistent epithelial defects, some graft-related complication like graft retraction or graft displacement or graft rectosis, and subconjunctival hemorrhage, hematoma, scleral thinning, suture granuloma. So one of the more deadly and side-threatening complications in case of post-pterygium surgery is it has been increased mostly because of use of mitomycin, which is which is a cancerous drug. Anti-cancer therapy is scleral necrosis or scleral thinning. So this is one of the potentially serious complication which can occur because of use of mitomycin. So most the common complications are so another thing is suture related complications, which I have not mentioned here. Like one I have told, so like suture granuloma. Similarly, suture irritation, it's the most common thing when we are placing sutures. Suture granuloma, suture irritation. Okay. So coming to the second short case, ideally we'll be giving either chalazion or antinomadium. If the case is not there, also we can just dictate you the case. So you need to know about all of these three infective conditions, like internal hordeolum, external hordeolum, and chalazion. So basically the definition is very important. Coming to hordeolum externum, commonly we call it as style. So the definition of external hordeolum is that's a suppurative infection of glands of Z's. So for that you need to know about the anatomy of lid properly. So in the lid, like, there are different types of glands, Z's glands, meibomian glands. So this you need to know. So stye is nothing more. It's an infective condition of infection of glands of Z's which are present at the lid margin. So the definition goes like this: it's a suppurative infection of glands of Z's. Coming to etiology. So etiology, since it is a suppurative infection, so it must involve microorganisms. So most commonly it's associated with staphylococcal infection, and symptoms of stye are, it's a painful condition. So they present with severe pain, which is sharp throbbing pain, and on touching they'll have more pain, like that is called tenderness. On touch, if you have pain, that's called tenderness, right? So increase of pain on touching the swelling or affected area, and later on, if it resolves, the pain, if the pus point is in and if the pus is evacuated, so pain subsides on escape of pus. So they usually come with complaints of painful swelling of the lid, either upper or lower. So there are two painful conditions. One is hordeolum externum and another is hordeolum internum. So how do you differentiate stye or hordeolum externum from hordeolum internum? That I'll be discussing later. So you just remember it is a suppurative infection of glands of Z's which are located in the lid margin. So hence they'll since it is an infection, suppurative infection, they present with pain which is sharp throbbing in nature in the lid associated with swelling. So, and they'll have tenderness, like pain on touching the swelling. Coming to the signs, so since it involves the glands which are present in the lid, so it usually initially it starts off with edema of the lid. It can be diffuse edema of the lid with chemosis, followed by localization of the infection. So sometimes it can remain like that. So one, it can go into preceptal cellulitis. So in the picture you can see there is a edema of the lid, and at one point you can see a yellow pus pointing, okay, and it is externally. So you can see a yellow pus point along the lid margin. So if the pus point is along the lid margin, along the hair follicle, because one thing you need to remember is these glands, they open into the hair follicles of the eyelashes. So if the pus pointing is towards the hair follicles in the lashes, it goes in favor of hordeolum externum. So you can see a yellow pus point along the lid margin around the root of the eyelashes. So the skin can give away and the pus drains out by itself with sloughing and followed by cicatrization. So the swelling subsides by cicatrization. So how do you treat it? So treatment, the most important line of management is we need to give warm compresses. Warm compresses at least twice or thrice a day. We can take a clean cloth, dip in a lukewarm water and place over the area. And along with that, we need to give topical antibiotic, either drops or ointment can be given. And if required, we need to give even oral antibiotics. Okay. Along with the topical or oral, we can give systemic, anti-inflammatory, or NSAID for the pain and for the swelling. And you need to remember most cases of odylium externum, they are self-limiting, they resolve by themselves, no need of going and doing any invasive procedures. Only sometimes without any treatment, if the patient they resolve. So if they're not resolving, if they come to the clinic, they need to do all this treatment like warm compresses, topical antibiotic, or topical antibiotic drops, or topical antibiotic eye ointment if required. If the swelling is large and if it's going for preseptal cellulitis, we need to give oral antibiotics also, along with oral anti-inflammatory medications. So another thing about internal odylium, the predisposing factors, like whom it is seen. More commonly, it is seen in young adults and debilitated persons, like very weak persons, or people who are having diabetes, because they say like hyperglycemia is associated with any infections in the body. So what are the predisposing factors? One is young adults, maybe people having refractive errors or having strain like over the eye, and in case of elderly people, it's mainly we have to, if it's recurrently happening or infection, we need to rule out diabetes. And coming to the third case, that is odylium internum, or internal odylium it is called. So the prime differentiating features between externum and internum. Externum, why we call, because the pus pointing is towards the lid margin, or we can see an external pus point, and it's mainly because of involvement of lines of Z's. Whereas in case of odylium internum, so it is also an infective condition, suppurative infection. So it's a suppurative infection of meibomian glands. So that's why anatomy is important, where the Z's glands are located, where the meibomian glands are located. Meibomian glands are located in the tarsal plate. They are away, they doesn't open at the margin of the lid. Whereas these glands are located along the margin and they open into the hair follicle. So this anatomy is important. So odylium internum is nothing but suppurative infection or inflammation of meibomian gland. So they say like odylium internum is more painful when compared to odylium externum, because the gland is the meibomian glands are located within the tarsal plate, which is a tough fibrous plate, and any distinction can lead to more pain. Hence odylium internum, it is more painful. Like you can see, this is odylium internum. So you can see an external swelling, but the pus pointing, the yellow point, is towards the internal side. So symptoms are again, they present with a painful swelling of the upper lid or lower lid, and signs. So these are the differentiating features. Like similar to external odylium, they can have a diffuse edema, swelling of the affected lid due to associated cellulitis. And here the swelling is more marked when compared to external odylium. It's more, and it is usually 4 to 5 millimeter away from the lid margin. There is something called marginal internal odylium, which is present along the margins also, but most commonly internal odylium is located 4 to 5 millimeter away from the lid margin. It's mainly because of location of meibomian glands, and it is more tender. And if you avert, you can see the palpebral conjunctiva, it is congested, and you can see a pus point which is visible from the inside. And treatment of odylium internum, since it is a suppurative infection, it's similar to external odylium. Same thing, like warm compresses, topical antibiotic eye drops or eye ointment, along with some oral NSAIDs, and if required, systemic antibiotics if there is any preseptal cellulitis, or if it's not resolving, then we have to go ahead with oral antibiotics. And if it's not resolving, and if the patient is having too much of pain, and if it's going for preseptal cellulitis or something, very rarely we need to drain. So even in case of external odylium, we do a simple procedure called epilation, that is removal of the eyelash, because as we know, the pus pointing is these glands open into the hair follicle. Just by removing the hair follicle, involving that gland, involving the infection, will drain the pus. Automatically, the pus will drain by itself. That is called epilation. So the treatment along, if it's not resolving by this, you can add epilation, or very rarely drainage. Okay. So what are possible outcomes of internal hordeolum? As all the internal hordeolum resolve by themselves, like external hordeolum, which is self-limited? No, usually they may resolve with evacuation of pus, or sometimes because they open along the palpebral side. So sometimes they may burst open on the inside, the palpebral conjunctiva side, and we can lead to secondary bacterial infection. And very rarely the internal hordeolum can persist and remain as chronic granuloma, that is chalazion. So this is a course of internal hordeolum. So most of the cases it resolves. Sometimes it can burst open into the underlying conjunctiva, can get infected, and very rarely it can become a chronic granuloma, which is not painful. That is chalazion. Okay. So the fourth short case is chalazion. So chalazion is again a important thing. So chalazion is also called as meibomian cyst or tarsal cyst. So differentiating features between chalazion and hordeolum internum or externum. This is a chronic non-suppurative granulomatous inflammation of the meibomian gland. So the pathogenesis is thought to be because of low-grade infection or of the meibomian gland caused by a very low virulence organism, leading to proliferation of cells and blocking the duct, which further leads to retention of the secretion. And retention of the secretions means like meibomium secretions, which is again an irritant, and hence leads to chalazion formation. So coming to the signs of chalazion. One thing I forgot to tell: what are the predisposing factors for all these infections, like hordeolum internum, externum, and chalazion? Like one thing I told you, it can be because of in younger children, if you see, because of strain, or because of the refractive errors, or in older people because of debilitating conditions like diabetes. Chalazion, most importantly, even in staph and hordeolum, the other predisposing factors are any late infections like blepharitis or blephro. Once again, so like blepharitis is one of the important risk factors, or especially for chalazion, acne rosacea or seborrhea, and seborrhea, or rarely like chronic, like some infective causes. So the predisposing factors you need to remember are chronic blepharitis, seborrhea, acne rosacea. And what are the signs? So usually they present as, because they are non-suppurative inflammation of the meibomian gland. So similarly, because of the location, they are located 4 to 5 millimeter away from the lid margin. Similar to internal hordeolum, there is something called marginal chalazion also, which is located at the eyelid margin. And then the swelling is hard on the conjunctival side. It appears hard on the conjunctival side, and on eversion you can see it appears to be red or purple in color. So on long standing it can become gray. It appears as gray. So what are the cause of the chalazion? So over a time it can become small, or very rarely they can resolve, but complete resolution may rarely occur. Sometimes they liquefy to form a thin fibrous sac called a meibomian cyst. Sometimes they get fibrosed, they form a hard nodule, or they get calcified. and rarely they can get infected secondarily. So if a chalazion gets infected, it is called internal hordeolum again. So similarly, see the course of hordeolum internum. So it can persist as a granuloma, that is nothing but chalazion. So similarly, the course of chalazion also, they can resolve over a time, or they can become smaller in size, or they can undergo some secondary changes, like they can go undergo calcification, they can undergo fibrosis, the secretions can get liquefied over a time, or rarely they can get infected, and very rarely uh, they burst through the conjunctiva and present as a fleshy mass. So like I told you, the clinical features. So and another thing is they can cause blurred vision if it's an upper lid chalazion, if it's a very large, if it's covering the if it's putting a pressure over the cornea, it can lead to astigmatism. Chronic chalazion, if it's not treated, it can lead to astigmatism, and very rarely it can lead to blurred vision. So but you need to remember the sequel of chalazion. Okay. So another thing is important point about chalazion is it can occur in either of the lids, or it can occur as a single or a multiple chalazions. And important thing, if it's recurrently occurring, and if there is atypical appearance of the chalazion, so and if it's occurring in elderly people, recurrently occurring, a large chalazion with a regular surface, external surface with prominent vessels, so you need to keep a suspicion of meibomian gland carcinoma. This is one of the important differential diagnosis for chalazion. So symptoms, okay, I've told signs before symptoms. Ideally symptoms have to be discussed first. So they present as a painless swelling away from the lid margin. Okay, sometimes if it's very small, they won't have they won't even realize there is a chalazion. It's mainly felt on palpation. So it can be single or multiple, it can involve either of the lid, and very rarely if it's a large chalazion, they can have inability to open. So what are the differential diagnosis? So very rarely recurrent chalazion or abnormally looking chalazion, it can be sebaceous gland carcinoma, it can be associated, it can be confused with sebaceous gland adenoma or carcinoma or foreign body granuloma. So treatment, so initially chalazion usually requires a surgical management, but if the patient is not willing, or if the patient wants to wait, so initially we can go ahead with a medical management, or we can, if the patient is present enough, we can wait for few weeks. So we can just wait if the swelling is reducing in size, and then go ahead with the surgical management. So the medical management, mainly it includes warm compresses, gentle massage, along with topical antibiotic around at night. So ideally chalazions are not self-resolving, so we need to go for a drainage or other modes like intralesional triamcinolone injection. So we need to inject triamcinolone acetate, which is a steroid, into the chalazion. So we need to avert and inject the triamcinolone acetate. That is one procedure, and the most commonly done procedure is incision and curettage of chalazion. So if it's a large, if it's non-resolving, if it's causing significant disfigurement or mechanical ptosis, yeah, another thing other than astigmatism, what it can cause is it can cause mechanical ptosis because of the large swelling size. So this comes under complications of chalazion, like astigmatism, mechanical ptosis, secondary infection. All this comes under complications of chalazion. So this is a procedure of incision and curettage. First we need to inject or infiltrate the local anesthetic, like how they are doing here. Externally we can infiltrate. Then this is a chalazion clamp, where the open side of the clamp is inserted internally along the palpebral conjunctiva, and the plate plate is externally facing. So we are holding the chalazion, and see, like this we are holding the chalazion and we are tightening the screw, that is called clamping. So this is a chalazion clamp. Followed by this, we need to avert the lid, like we just seen in the third image, we are averting the lid. So right now we are seeing the chalazion. Always the draining is mostly done internally, like a few textbooks have mentioned, like internally we have to put a vertical incision, externally we need to put a horizontal incision. Mostly we do a internal drainage. So here with the blade we are putting a vertical incision and we are evacuating the contents. So why we need to put a vertical incision? Because the meibomian glands are located vertically. So if we are putting a horizontal incision, we are cutting the ducts of multiple glands. If we are putting the incision, we are putting parallel to the gland or only involving that gland. Okay, there won't be damage to multiple glands. So very rarely, if it's opening, if it's a large which is opening externally towards the skin, if we need to do put an incision on the skin, we need to put a horizontal incision. That is for the cosmetic reason, because like vertical incision along the skin doesn't approximate properly, and it leads to cosmetic blemish. That's why we need to put a horizontal incision, which will make a lid crease. So this is all about the commonly given short cases, and pseudophakia will be dealt with the Satyalakshmi ma'am, along with the cataract. She'll be dealing with a long case. So thank you.